So without further ado, welcome everybody to our webinar. If we haven't met, I'm Dr. Melanie Bechard, or Mel, Chair of Canadian Doctors for Medicare, also called CDM for short. I'm very grateful that you could join us tonight. We really need strength in numbers. This is an all hands on deck situation because we are confronting one of the biggest attacks on Medicare in recent years. I do want to get us started with a land acknowledgement. While we are meeting virtually, the Canadian Doctors for Medicare office is located on the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit peoples. Toronto is within the lands protected by the Dish with One Spoon agreement. The dish represents the land that is to be shared peacefully, and the spoon represents the individuals living on and using the resources of the land in a spirit of mutual cooperation. This agreement captures our responsibility not only to the land, but to one another as well. And I encourage you, as we have these discussions about our healthcare system, to reflect on the responsibilities that we have in healthcare, to reconciliation, and also to the relations of the place where you are joining from. And at CDM, we do want to always recognize the disproportionate and unjust disparities that Indigenous people continue to face today due to racism and the ongoing effects of colonialism. And we are committed to working to reduce these inequities as a big part of our work in advocating for better Medicare. Before we begin fully, just a few quick housekeeping matters. This webinar is being recorded so it can be shared with those who can't join us this evening. Of course, please feel free to send chat messages to attendees. We would love to hear from you in the chat box. Feel free to message right now. I'd love to know where you're calling in from, why this is important to you. Maybe you can also share the traditional territories that you're calling in from. You can ask questions through the Q&A function at any time. We'll have a little bit of didactic portion first and then a general Q&A. So please don't be distressed if we don't get to your question right away. We will try to get through as many as we can. And closed captioning is available and can be turned on through the Zoom platform. This event will run for about the next hour or so about 8 p.m. Eastern, 6 p.m. Mountain Time. You can do the math if you fall outside of those regions for now. That's just where I happen to be. But thank you so much for sharing your evening with us. So before we really delve into things in our conversation with our panelists here, I did want to set the scene for a little bit. This webinar is called What's Happening in Alberta? In addition to some bad weather, Bill 11 just passed a final step in the Alberta legislature, and at Canadian Doctors for Medicare, we are extremely concerned about Premier Danielle Smith's plan to allow physicians to work simultaneously in both the public and private healthcare systems. There is a lot to unpack tonight. There's a lot of changes that have been proposed. From what we know so far, Alberta is preparing to introduce private pay healthcare, and employer-based insurance companies are salivating. They're ready to seize the opportunity to make a profit off of this system. And what's unfolding could set a dangerous precedent across the country. This is something that we do believe, yes, everyone in Alberta should be concerned about, but more importantly, and even on a grander scale, everyone in Canada should be concerned about this as well, too. This is not a single province issue. We see these machinations happening across the country. Alberta, I think, is arguably maybe leading the way, but this is not going to be an isolated battle. We know that already. From dual practice to duplicative insurance to private pay diagnostic imaging, all the changes that are potentially being proposed would undermine access to publicly funded healthcare and worsen wait times for the vast majority of Albertans. And essentially, the government of Alberta is eroding Medicare as we know it. Currently, every province except Ontario allows physicians to opt out of the public healthcare system. This means that physicians can opt out and practice medicine and charge whatever price the market will bear for their services. Outside of Quebec, very few physicians engage in this practice because of the financial risk. Not many patients are willing to pay privately for services that they could access free of direct charge through the provincial or territorial public healthcare plans. Dual practice would essentially enable physicians to mitigate that financial risk by charging patients privately if they are willing to pay, while still relying on public payments for everyone else. Dual practice has not been permitted in Canada because of the clear negative impacts on access to care. We really appreciate your concern and your presence here. We did want to give a special shout out to the several medical students from the University of Calgary and University of Alberta who are here with us tonight. Now, let me get into our panelists who are joining me on this virtual stage. We are joined by physician and community leaders in Alberta to help us better understand the issue, what is at risk, and how we can chart a path forward to try and defend and strengthen Medicare in Alberta and across the country as a whole. First off, I'm very pleased to introduce Chris Gallaway, Executive Director at Friends of Medicare. Chris is an experienced community organizer and a strong advocate for public health care. Born and raised on a farm in rural Saskatchewan, he spent most of his adult life on Treaty 6 territory, first in Saskatoon and for the past decade in Edmonton. His extensive experience includes work with the Alberta Federation of Labour, 3 provincial legislative assemblies, and a range of nonprofit and community organizations. Please join me in providing a virtual round of applause for Chris Gallaway. Thank you. I know, a little virtual silence there, but I know you're applauding. And then you'll also notice that we have Dr. Thara Kumar here, who is an emergency doctor in Red Deer, Alberta. Dr. Kumar has been a stalwart member of the board of directors of Canadian Doctors for Medicare from 2019 until very recently in 2025. Just as soon as she had finished her term with us, these changes were proposed. So Thara has been very kind at sticking around with us and helping out, despite not officially being on the board at this moment. So without further ado, we have some prepared questions for our panelists that I'd love to jump into. This will take about 15-20 minutes or so, and then we'll open it up to the general Q&A. So my first question is actually for Thara. We are on a first name basis here. We don't really do Mr. Gallaway or Dr. Kumar, just so everyone knows. Please set the stage for us. What is it like practicing medicine in Alberta right now?
I'll actually only respond to doctor, so that's going to be a huge problem for me here. No, I'm joking. Thank you so much for organizing this panel, Mel. I'm so happy to be here. I have to apologize first. As you can probably tell, I am struggling with a bit of post-viral laryngitis. And so I'm probably not as clear as I'd like to be, but hopefully I can make it through the hour here. Um, so I will just start by saying I'm a born and raised Albertan. I've had the chance to practice a bit in Ontario, but I've spent most of my life and my career here. I'm very proud to be an Alberta physician. I think that the experience of being a physician here is probably very similar to what physicians are experiencing across the country. I think that we're seeing that we're very fortunate in Alberta that we've generally had a relatively well-funded healthcare system. I feel generally that I'm able to provide my patients with some of the highest quality of care that is available anywhere in the world. And I feel really good about the people I work with, the services we can provide, and the fact that I can provide that very high quality healthcare to people at no cost to them personally. And that's been a really great experience. I think, like every physician in the country, we're very concerned about things like access block, wait times, the growing pressures on our publicly funded healthcare system. And so, for many years, all of us have had top of mind ways that we can work within the public system to try to improve access, reduce wait times, and make our system, which is already founded in excellence and equity, to be able to function better for everyone. And I totally recognize that this system is not working perfectly as it is, and there's lots of room to improve, and we're all very aware of that. I would say since this proposal came out, there has been a shift in the level of anxiety that I'm seeing among providers in the public system. I think we all recognize that if this goes through, it could really be, although it's kind of the final step in a lot of steps that have been taken that feel like they're aimed at dismantling our healthcare system. This one really feels like it could be the final blow, where I think the sense is that if this happened, it could be irreversibly devastating to our publicly funded healthcare system and irreversibly damaging to patients who are relying on the public system for care. So that's brought about a lot of anxiety and a lot of fear. I hope you can understand me. I'm so sorry about my voice today. But yeah, I would say that's kind of where we're at right now in Alberta.
You sound great, Thara. Thank you so much. Your message is clear, even if your voice is failing, coming in loud and clear. I wanted to echo too, as a physician practicing in Ontario, times are tough, especially this flu surge. I feel like half of us on the panel are dealing with flu right now, as you can hear. But the emergency departments are bursting across the country. And none of us here are here to defend the status quo. I think we are all very much proponents of major change in healthcare. We just know that that change that will be helpful is not going to be charging patients for essential care. I did want to give a few shout outs in the chat. Thanks to everyone who's coming here. We've got some prior board directors, some prior panelists of prior webinars. For Jack Etkin, thank you for the invitation to your YouTube channel. Please send us the details to info@canadiandoctorsformedicare.ca, and we're happy to look into things and potentially set something up. But continuing on with our questions, so we heard a little bit from Thara's perspective about what it's like practicing medicine in Alberta right now. Chris, what are the people in Alberta saying about the health system right now in a broader sense? And then second to that, what are they saying about Bill 11 and this proposal to allow dual practice?
Absolutely. Thanks, Alan. It's great to be joining folks from Treaty 6 here in Alberta, where it's very snowy and blustery, and I'm glad I can do this from home tonight because I did not want to venture out. But in terms of what I'm hearing, part of my job is traveling all over Alberta, listening to Albertans and talking to them about healthcare. And for the last couple of years, the top concern, no matter if people are living urban or rural or in the south or way up north, everywhere I go, the top concern is access and accessing the care people need, whether that's not having a family doctor, whether that's concern about facility closures with closed emergency rooms or obstetric services or acute care, or concerns about an ambulance being available when they call, or just the wait times in general, the waits at emergency rooms for diagnostics, for surgeries, for cancer care now. There's so much concern about accessing the healthcare that they need when they need it and in their community when they need it. So that's what we've been hearing for a long time, that Albertans want that concern about access addressed. Once they access the care, they have great things to say about it. It's those waits. So to tie into your question about Bill 11 and the impact, the other concern that has been growing over especially the last year is this idea that folks will have to pay out of pocket for healthcare that they need. We saw that with our COVID vaccine rollout. We've seen that with diagnostics and different privatization schemes and membership clinics and that have been popping up and growing over time. It's an increasing concern. So with the tabling of Bill 11 and the idea of a fully two-tier system with a public and private diagnostics and surgeries and physicians and so on, people are very worried about what the cost of that will be and how they will access it if they are going to have to pay out of pocket or seek private insurance or hope for employer covered insurance. People are very, very worried about that cost, and they know for most people, especially living more rural, that they're not going to have that healthcare available for them if we move to this profit motive system. So there's a lot of unrest and concern right now from folks that, one, they can't access care, but two, now it's going to be even worse and it's going to cost them a lot of money.
That's a great point, Chris. Thank you. Yeah, it makes sense. Delivering healthcare in rural areas, hard to make that profitable. If we do move to this more corporate model of medicine, that'll make these really difficult barriers we already have in delivering care in rural areas even harder to surmount. Thara, I know you touched upon this a little bit, but what have you heard amongst your colleagues? What did doctors in Alberta think about Bill 11's proposed changes?
Yeah, I think it's definitely a controversial proposal. There's mixed opinions on it. And I don't want to pretend that I speak for every doctor. I would say overwhelmingly people that are working in the public system are very concerned about this bill. I think we're very aware that all of the evidence suggests that this is only going to further reduce already very limited resources that are available to the public sector, and it's going to increase wait times for patients who are relying on the public sector for care. I think those of us who are already in a world of very long wait times, and I'm in a situation where I'm already seeing that we don't have enough physicians anymore in Red Deer to fill our call schedule. And there's nights where we don't have a cardiologist available or nights where we don't have an ENT surgeon available. I think, in my environment, we're all saying what's going to happen when we have even less doctors available, and what is that call schedule going to look like, and how are we going to access care for our patients coming into the emergency? And I think that's a really scary thought for a lot of us. Now, I don't want to pretend that there's not anyone who is in support of this idea. I think it's important to acknowledge that there are physicians who see merits to this. I think it particularly appeals to surgeons who are really struggling right now with the fact that they don't have enough operating room availability to get through their lists, and they have huge waiting times as a result. So I've definitely spoken to surgical colleagues who are just looking for any opportunity to be able to operate, and whatever that looks like, they'll take any chance they get to operate more on more people on their list, whoever that may be. But when I talk to them about this more and I say, well, if you were offered an alternative way where you could operate more, but in the public system and for the next patient waiting, not just whoever on your list can pay for it, would you do that? And they all say, absolutely, that would be their first choice. I think the challenge we're facing is they're not being offered that. And there doesn't seem to be a lot of interest from this government in developing solutions to improve access to OR times in the public sector. And when the only solution they're being offered is the option of private delivery of services, some of them are willing to take it, but it's certainly not a first choice from anyone I've spoken to.
Yeah, thank you so much for outlining that, Thara. I think that matches the conversations we're hearing. People are eager for any way to reduce wait times. And I know I'm absolutely preaching to the choir here, but having people pay privately for care doesn't necessarily reduce wait times. In fact, we find that the wait times are often longer for the majority of people. It rearranges the wait list so that those who have the financial resources will be put at the top. But we have to keep in mind that the bottleneck is typically the healthcare providers and people who are actually doing the surgeries, who are seeing the patients. We're not injecting any new healthcare providers into this system. We're not making our system more efficient. We're just rearranging that wait list, which is why we don't see this as a very viable solution. And I think when I explain it to my colleagues that way, they kind of understand because people are so eager for change. I did want to point out a few things happening in the chat. Zarif Ahmed, who is our National Director of Canadian Doctors for Medicare and is bravely here despite battling the flu tonight, has posted the Friends of Medicare statement on Bill 11. So some great reading if you want to read up more. It's the concerning comment from Carol Waddick. Thank you for raising it for us about central booking kind of being used to delist procedures because CDM has been a big advocate of centralized referral lists. This is an evidence-based way to really reduce wait times. So it sounds like maybe that is not being implemented as it should be. And lots of nice hellos from folks in the chat. Hello, yes, from Ottawa. And I see there's Jake Thorsteinson, who has written a comment and linked the statement from Alberta's medical students. Thank you so much. And thank you for citing us. That is wonderful. Okay, I can't keep up the chat. It's going too much, but that is wonderful. A good problem to have.
If you don't mind, just add to the last point too, that the one thing that people often forget is even though surgeons, are maybe available to do more surgical time if they're given that time, the real rate limiting step for sure in Alberta and I think everywhere is the shortage of all the other staff that support the OR. So we have a huge shortage across Canada of anesthesiologists right now. We have a shortage of OR trained nurses. And so opening up a private OR somewhere or opening up OR time to private pay patients does not increase the number of anesthesiologists or the number of OR nurses. And so all that's going to do is take away further resources from people who are waiting on the public sector wait lists for those surgeries. And we've seen this play out in many other countries that have tried this, where it's only increased the wait times in the public sector.
Perfect. Thank you for outlining that so clearly, Thara. All right, I have a question for either or both of our panelists. Obviously, this change has not happened in isolation. Danielle Smith has been rolling out several changes to the healthcare system. And I'm wondering, over the past 3 years or so, since 2022, how has Premier Danielle Smith changed Alberta Health Services and the health system overall?
You want me to go and save your voice a little?
Sure, why don't you start, Chris? Thank you.
Yeah, well, I think we need to remember we had an election a couple years ago, and in that election, Danielle Smith ran on a public health guarantee that no one would have to pay out of pocket, and she didn't run on anything she's been doing since to public health care. To get to the answer of your question, since being reelected, they announced this massive restructuring of Alberta Health Services, blowing up the whole organization into 4 pillars, and then, a half dozen more agencies underneath that, contracting out more and more of that work to for-profit providers underneath those agencies, coming after public health, delisting services, and so on. And now this move towards a fully 2-tier system for diagnostics and surgeries and potentially one day family medicine. Not yet, but they're looking at it, were their words. None of this was in a platform. None of it was sent to Albertans. They were told a public health guarantee looking at reducing wait times. So no matter how anyone voted, That's what they voted for, was public health care. And instead, we're getting the total opposite. And it's been very methodical. There's been, legislation and steps taken to go after our public hospitals and queue them up for privatization in terms of ownership and funding and creating a competitive market. So it's been very methodical over multiple years to get to this point of Bill 11. So there's been concerning steps every session. There's been massive omnibus healthcare legislation that makes huge changes to our healthcare system, to the rules, to the regulations, and the contracting out. And now we're at Bill 11 that really is the government admitting their real goal is just having a fully two-tier system here in Alberta and bringing in insurance companies to be part of that, which they hadn't admitted till now. But it's very different than what we were promised in the election.
Yeah, I completely agree with that. I think this is certainly not what was promised. I think it's what a lot of us feared. And I think that up until now, there's been a lot of little micro steps that have felt a lot like they are creating the framework and the pieces that they need to have in place to be able to eventually support a parallel private pay system. And now Bill 11 feels like the very clear end to that sentence, like, oh, here it is. Here's what we've been waiting to see coming. Because all the bits are there. They've been building CSFs. They've been consistently, not only in healthcare, but in many areas, really moving away from people who work in those areas, whether it be healthcare, education. They're moving away from kind of experts being involved in policy making. There's been a lot of taking away the role of experts and people who work in the fields in decision making, moving away from evidence-based decision making, and a lot of very ideology-based decision making. And I think Bill 11 is kind of the final culmination of that from a healthcare perspective, where we're really seeing a lot of our fears now coming to reality.
Thanks to you both for outlining those recent changes. I do see a question from Michael Ratcliffe in the chat. Feel free to put questions in the chat. I just might miss them. The Q&A, they're tracked a little bit easier, so I'll briefly address it now so that it doesn't get lost. But Michael is wondering if Danielle Smith is banking on Prime Minister Carney ignoring the federal role in healthcare, and do we know what the feds are thinking? So I can share a little bit because at Canadian Doctors for Medicare, we do meet regularly with staff in the Federal Minister of Health office, and we do also meet with the Canada Health Act Division of Health Canada. And I can say that both parties are very aware of and very concerned by this, I think very appropriately so. There is the ability to essentially enforce withdrawals of Canada Health transfers to withdraw funding from Alberta if they do proceed with this change, if it is deemed to be in contravention of the Canada Health Act. I think we can get into that a little bit more because I saw some questions in that flavor in the Q&A. But there are mechanisms, and I do think that there is a strong chance that there will be these changes imposed in Alberta if they do go through. Right now, they're kind of waiting for details. We know what the legislation looks like, but we don't know exactly how things will be rolled out. There could be some regulations that change things. I think right now we're all trying to see exactly how things will play out. But it is hard to imagine how any regulations will neutralize the very concerning plan for dual practice that is very clearly outlined in the legislation. So I think we have some goodwill, but like anything, we have to keep in mind that our elected leaders cave to public opinion. Essentially, that's their job. And there is always at risk if they're not feeling pressure from the public to enforce something or to act on something, they will take the path of least resistance. And I think it's very important that we hold our leaders to account at the federal level and say, hey, this is not okay. The harder they make it for Alberta to roll this out, I think the less chance there is that it'll roll out in other places. I think the better chance there is of saving Alberta's healthcare system and Canada's at large. So we do have to make some noise. We're trying to use our channels at Canadian Doctors for Medicare, and I encourage everyone here to use whatever channels are available to you. Okay. This is a question for either or both of you, and I know we've touched upon this a little bit, but how might Bill 11 impact access to care for patients in Alberta?
Oh, yeah, I think we've kind of discussed this a bit, but I think one of the biggest limiting factors is human resources in our system. So this system, although it might create a parallel private pay option, it does not come with a plan that's going to at least in the short term, and I think even in the long term, adequately increase the number of physicians, nurses, techs, all of the other human resources required to support those healthcare systems. It's not going to double the number of people that we have to work. So anything, even if it takes away 10% of our services to the public sector, or even they've discussed maybe having rules about having to put a certain amount of work time into the public and the private. But regardless if it's taking anything away from our public sector, it's going to mean fewer resources available for people who are relying on the public sector for their care. And I suspect that we'll disproportionately lose providers over the number of patients who are moving into that system, which means that we're going to have a lot more people waiting in the public sector with far fewer resources to provide their care. And we've seen that play out in many other examples. We saw that in Saskatchewan when they introduced private pay diagnostic imaging. It actually doubled the overall wait time for MRI simply because it created such a huge increase in demand for imaging, but the actual availability of MRI machines was not adequately increased enough that it reduced the wait times. And we saw this huge increase. And we see in Australia that the wait times for surgeries in the public sector are about twice what they are in the private sector. And so I just foresee that this is going to cause huge increases in wait times for those who can't afford to pay. And like you said, Mel, it doesn't shorten the overall line. It just rearranges the line to prioritize those people who have the financial means to pay. And the other really critical thing that I think people need to understand is that this private pay system that they're talking about is only ever going to be able to do low risk elective type of procedures. So when it comes to emergency care, life-threatening care, complex care, if you or a loved one are critically ill, even if you have the financial means to access the private system, that's not going to help you. We're all going to have to continue to rely on the public sector for emergency ICU, life-threatening, and critical illness care. And so if that system is crumbling because of lack of resources, every Albertan is going to suffer when it comes to their time of need.
Yeah, and just to add to that, and I'm so glad you pointed to that piece of it. We have a real life example here in Alberta with the government's obsession with using our public healthcare dollars for private for-profit surgical centers and really prioritizing the work of like knee and hip surgeries pretty much, because those centers can only do those less complex, simple procedures. And what we've seen is we put more and more resources into those facilities, hundreds of millions of our public healthcare dollars, that our public operating rooms are often sitting empty, they're understaffed, and our wait times for all of those other surgeries are going up. We have cancer surgeries and other serious surgeries, broken hips, and so on, that the wait times are going up and up and up as we put more and more public resources into one type of surgical center in the private system that's a for-profit system, which is also allowing queue jumping on top of it. So we've already seen what happens if that is our focus here in Alberta. We have longer wait times for surgeries because of our push to a secondary system, because we don't have the workforce to staff two systems right now. Those shortages are real. And if we put an incentive to put more people into a for-profit system, that's where the workforce will move and everyone else will be waiting longer or going without.
Thanks to you both. I did note that in the chat we have Geneviève Lamarche, who has posted a statement from the health coalitions about the issue. And Manisha Dar has also shared a petition from the Canadian Health Coalition. So please direct your attention to that if that is of interest to you and you're able to find those in the chat. I do see some questions in the chat. Please put them in the Q&A. I'm trying to write them down so that they won't get lost. But Sonia asked a question, and part of her question is what I was going to ask Thara next, actually. What has been the role and response of physician groups like the Canadian Medical Association or the Alberta Medical Association in these discussions about Bill 11?
So I think, one of the most concerning elements of this was that the Alberta Medical Association, who is supposed to be our liaison with government on policy issues like this, was not actually consulted in the development of this bill or any of the elements contained within it. So that in and of itself is very concerning and is quite consistent with this government's pattern of generally leaving out expert opinion or people who actually work in the field in decisions that are very relevant to those sectors, which is very frustrating to not feel like we have a seat at the table. I think the role going forward, now that this has been proposed, is going to be critical for physician-based organizations to really advocate for the policies that we want to see and make it clear that this is not something that we want. I will say it's a little tricky for the Alberta Medical Association, I think, because they do ultimately have to continue to work with government on things like negotiating salaries and physician contracts and billing codes. And so I think there's a bit of a limit as to how aggressively they can push government on these issues or kind of antagonize policies that have been proposed. And that's where I think other agencies are actually going to be so critical in this conversation. The CMA has a little bit more of that arm's length, working directly with the Alberta government. So I really hope that they can be very strong advocates on our behalf. And that's why I think organizations like CDM and Friends of Medicare and those other organizations with a health policy interest who don't have a direct relationship with the Alberta government are really such critical voices right now, because that's the only way that we're going to be able to really call this out for what it is and make it very clear that we don't want this.
Thank you. I did see a question in the chat about, what are these levers for change that we're working with? I can talk about Canadian Doctors for Medicare in a little bit, but Chris, maybe you can enlighten us and share some of the work. How is Friends of Medicare advocating for change?
Absolutely. And I want to say, specific to Bill 11, this has all happened very fast. The government tabled it within days. They used closure motions to limit debate. With less than 4 hours of debate, they rammed through a 300-page piece of legislation that amends many acts. And just today, right before this webinar, they released 16 new orders in council with regulations associated. So, it's been a very quick reaction, but we continue to advocate to both the federal and provincial government the best we can. We're really trying to work in building and growing coalitions. We exist as a coalition, as an entity, but also working with the Canadian Health Coalition and all of the other coalitions on that statement that was shared in the chat to the federal government, asking them to act. And I know the Canadian Health Coalition is hosting the email tool where people can write in to the federal health minister and their MPs saying we need federal action on this. But then it's doing that organizing work to get Albertans engaged in pushing back, in reacting, in advocating. So we have town halls, we have a campaign online, rebuildourhealthcare.ca. It has an email tool. We're doing all sorts of work with our local chapters and volunteers to be out in the world as much as possible to, one, tell people what's going on, which is why we're doing this town hall tour and other events that we've been doing, but then two, to say, we need you to do something right now. This is the moment where it really matters. And if we don't want to see the loss of our healthcare system across the country, our universal single payer system, this is the moment you need to take action. And we're seeing people do that, not just by sending the emails, which is important, but by signing up, by forming new local chapters and communities, by volunteering. We're tabling at holiday markets and events all over the province right now to really try to get that word out. And we're going to be doing more town halls all over rural Alberta in the new year. I think we have 10 more scheduled already that we're going to be out there talking to folks. We were lucky to have Thara at one of them in Red Deer recently, and hundreds of people are coming out because there is a lot of interest right now, but it's really reminding people that we need them to be willing to take action if we're going to push back. It can't be the couple of staff at Friends of Medicare that are somehow going to achieve change. So really, it's that mobilizing piece that we're into now.
All right, Chris, I feel like you outlined this really well, but to make it super explicit, let's say I'm from Alberta, I'm listening to this webinar right now. What can I do? How can I help Friends of Medicare combat these proposed changes?
Absolutely. Email the federal government to tell them to act. Now, using our tool on our website to your provincial representatives to tell them you don't support what they're doing. And if you want, sign up to our list, sign up as a member. We have local chapters that are volunteers and communities from Lethbridge and Medicine Hat all the way up to Fort McMurray. So there's one in your region. You could get involved doing that work on the ground of, dropping door to door or tabling in public or having events or so on to really reach as many people as possible. So there's lots of ways to get involved, and they can sign up through our website to do that, but don't underestimate writing to our representatives and getting others to as well. We were in Ponoka the other day for a town hall. We had 75 people there, and I was like, if you all write into your local MLA today, that's probably more emails than they've got on any issue in a long time. and then go ask someone else to do it too, and really show these government MLAs that they're implementing something that no one voted for, and that no matter how people voted, when you ask them, they don't support it. The vast majority of Albertans want single payer healthcare, and we need to remind each other and our government of that.
Oh, amazing. Thanks, Chris. Getting goosebumps. I see Zariz is also posting many helpful links in the chat as well, too, for the Friends of Medicare campaign website, how you can contact your local representatives, and also a list of the upcoming town hall. So please do take a peek at that for everyone. Zarif, I'm impressed you were on the ball. I don't know if you had those links ready to go or if you were going on the fly, but the flu is not slowing you down. You were winning this fight. Okay, final question that we have pre-prepared for either or both of you. Um, Clearly, healthcare needs major change. I know we've already spoken about it at this chat. Nobody here wants the situation to remain the same. There's been some discussions in the chat about how our health system is relatively expensive. We do spend a relatively high amount compared to other countries, and yet our outcomes are mid at best sometimes, and by some metrics, they're quite bad for other countries. Um, what are some better ways that we can improve Canadian healthcare in Alberta or across the country overall?
Yeah, I think there's a ton of ways that we could really focus on the bottlenecks within the public system. Again, no one here is pretending that our system works perfectly. I think we can all see the failings and the access block. But lots of evidence-based ways to address that within the system. We already talked about centralized referrals and intake. Very strong evidence to suggest that changing referral pathways so that they go into a centralized intake and then get looked at, optimized, and then sent to the specialist with the lowest appropriate wait time, rather than referring to individual providers, is a far more efficient way of doing it. And we've seen wait times in specific services cut in half just by making that one simple change. So very low hanging fruit. I think we need a lot more investment in our primary care and preventative health areas. We need to be able to make sure that people have access to preventative care, to early knowledge and understanding about healthy lifestyle, about being on medications so that they can prevent their illnesses from getting worse. We need actually more investment in public health care, not less, in terms of expanding our public health care to include things like pharmacare and dental care. We need people to be able to afford that preventative health and early intervention in their health so that they're not ending up with really critical illness or further complications from their illness that then result in more expensive, costly, and difficult for the patient stays in hospital. We need more investment in pardon me, long-term care, where we have people, again, not having to get stuck in the hospital admitted for many days longer than they need that acute care, to have a safe place where they can transition to outside of hospital into a long-term care or assisted living type of environment. And finally, even some of the things they've talked about as part of Bill 11, like they've talked about opening up OR time in the evenings and on the weekends and having, extra payment or other models of recruiting people to work those extra hours. Fantastic. Let's do it. But let's not just do it for people who can afford to pay. If we're going to do that, let's open that up for everyone who's on the public healthcare list and just try to optimize the resources that we have to make them as available as possible for the patients who are waiting.
Yeah, we should do all of that. That sounds like a great answer. I think it's also important to remember, we are spending a lot of money on healthcare, but how we're spending it matters, and there's ways we could do that better. If we stopped wasting hundreds of millions of dollars on failed privatization schemes, like our contract for labs with Dynalife that we just got the Auditor General report on canceled contracts, on the profit margins we're adding in to all of those surgical centers, to the laundry and food services contracting out, to the diagnostics and so on. We're paying for profit with public healthcare dollars instead of for care. So yeah, there's a lot of money out there already that could be spent differently. But then it's also the solutions piece of it. We desperately need a workforce plan for healthcare in Alberta. We're doing no workforce planning. We have mapped nothing out. We have no idea who we have where or what the vacancies are. There's no plan for retention or recruitment, let alone training and looking to the future. And our population's booming. That is the biggest problem in the system, is the short staffing, which is leading to the lack of access to care. And we know that a two-tier system will only make that worse. But it's also investing in those things that have been mentioned, where are bolstering primary care and public health and preventative care with evidence-based public health and preventative care strategies instead of the opposite, to do things that reduce the burden on our overcapacity hospitals rather than pushing everything in there. The social determinants of health being part of our governing system instead of pushing all of our social problems into hospitals. And, I'm thinking about it today with the weather outside. We just got the stats from last winter again, and we've set another record for frostbite amputations in Edmonton because we're driving people without housing into emergency rooms and operating rooms and spending money on that instead of having affordable housing for people. Being the frostbite amputation capital of the country shouldn't be something we're proud of. It shouldn't be seen as good news. And it's actually a really stupid way to spend dollars on healthcare, even if you don't care about the humans. I think you should care about the humans who are having those traumatic incidents, but it's also a very expensive way to approach things. Pharmacare is an example of that, long-term care, all those things that have been mentioned, and also the little tweaks. And don't underestimate the power of those central wait lists, of breaking down the silos a bit, of the coordination. But instead, we're going the opposite route where we're pulling all of Alberta Health Services apart into more and more silos, where we're very worried that patients are going to get stuck more and more between systems and agencies, as no one is really responsible for the overtop part of their care. So there are boring administrative solutions, but the bigger solutions are workforce planning and how we actually spend our dollars, putting it to care instead of profit.
Perfect. Thanks to our panelists. I do see some comments in the chat about health funding in Canada and how we have a challenge set for us simply because of our geography, massive country, lots of remote regions. That is a challenge. We're probably always going to have some expenses there that many other countries don't experience to the same extent. Michael Rackless is pointing out that we're actually kind of in the middle in terms of the percentage of spending of GDP compared to other high income nations. So that's extremely fair. One thing that strikes me that I always find quite surprising is the percentage of overall health spending that is from the private sector versus public, where depending on what you're looking at, about 30% private, 70% public. Despite having this quote unquote universal healthcare system, we recognize that there is a lot of private spending. We see it in the realm of mental health. We see it in the realm of dentistry, although there has been some moves with the Canada Dental Plan, an imperfect program, but some progress, one might say, and especially in pharmacare. But that is a whole webinar in and of itself. So I'll redirect back to all the wonderful questions in the Q&A section. So there's a question from HB. Is there any legal recourse against Bill 11? Doesn't that violate the Canada Health Act? I know we kind of addressed this earlier with a similar question in the chat about whether or not the federal government will enforce the Canada Health Act. It depends who you ask, of course, but I think that the vast majority of folks that I've spoken to, even those who do have a legal background, do feel as though Bill 11 does clearly violate the Canada Health Act. The Canada Health Act does not have the words dual practice is prohibited, but the effects of dual practice and how that creates clear inequities and barriers in access to care clearly violate the spirit of the Canada Health Act. I think that is something that the vast majority of people can recognize. And because of that, the federal government can essentially follow the recourse of reducing or stopping federal health transfers to Alberta. So that would be the sanction that would essentially be proposed and that they would have the ability to do. So we're very hopeful that that will be the outcome of this. I don't know if Thara or Chris have anything more to say on that. Please go for it.
Just add real quick that we believe that it's not what the Canada Health Act intends, and we do want the federal government to look and do that. But regardless of the legal case, and there's been Canby and other court decisions that would argue that this absolutely is not the way we should be going. But I don't think we should count on courts to save us. We know that in Alberta with the use of the notwithstanding clause and so on, our government doesn't really care that much about the legal system right now. But the federal government could act regardless. For years, we've been calling for a new federal health accord with the provinces where there's strings attached to federal money. They have that power. They could do that. That we haven't seen that in years now. But I'm sure Canadian Doctors for Medicare and others at times have also called for a renewed health accord. And they could tie strings to money that way. It doesn't have to be an enforcement of the Canada Health Act. They could do it with the pharmacare money on the table and so on. So, of course the act matters and they should enforce it, but they're not powerless regardless of just that one piece of legislation.
I think that's a really important point. And I think my fear with this is that if we rely on the court system to sort this out. If this is allowed to go forward and this two-tier system is built, and then it goes to the court system, which may take a decade or more to be able to really reach a resolution, I think by that time, our publicly funded system will be so irreversibly destroyed and dismantled that it will be very hard to ever come back from this. Once we have split our system, I think that it's going to be incredibly difficult to ever, bring it back together in a way that will be effective and meaningful. So that's why I think this is such a critical time where I hope we can advocate to the federal government to take action before this ever happens and to stop this thing from even getting out the gate. Because once it does, it's going to be just exponentially harder to bring it back.
Thank you to you both. We have another question in the Q&A section that I'll try to summarize a little bit for the sake of time. But essentially, Crystal Schatz has heard that 2 actions that could potentially ease the system would be to increase medical school admittance and to centralize wait lists. And they're wondering, what are the barriers to this? Are there logistical issues? Why is this not being done?
Well, I think we spoke a little bit to the decentralized wait list is that I think that's referring to centralized intakes that we spoke about before. So definitely that's something that we need to see more of. Alberta actually has been instituting that now. There's a system now called the FAST system. I forget what it stands for, but it's essentially a centralized referral intake that a lot of surgical services are now using. So it is happening, which is great. I think hopefully it will become more widespread as more and more doctors are brought into that fold. And then in terms of medical schools, I think that it is the challenge with the medical school investment is that it helps us in 10 to 15 years. So that really is a long-term timeline that we're looking at. It's really critical to do because our workforce problems are not going away anytime soon. But it's harder to get buy-in because governments are mainly focused on the next 4 years. And if they invest in that, it's not necessarily going to bring meaningful benefits that will help them get reelected in 4 years. So I think it's not always a sexy solution. The other thing that Chris already alluded to is there's not actually a great plan in Alberta for how many more doctors do we need? Where do we need them? What specialties do we need them in? I think that we're just missing a lot of planning in terms of recognizing what we need and then being able to take meaningful action. Because increasing a bunch of medical school spots won't actually help us if all of those physicians then go into subspecialty surgery. We need people going into rural family medicine and family medicine in general. So we need to find ways to not only increase the number of spots, but do it in a way that's meaningful. Make family medicine an attractive specialty again. Make it something that people want to do, like incentivize people to work rurally. And so we need to do this in a thoughtful way that is targeted to a workforce plan that actually understands the needs of the province.
Absolutely. And I see a comment from Jake Thorstensen in the chat who's saying we barely have capacity for more medical students as it is. Oh my goodness, you guys. Sometimes I will have an ED shift where I have 2 residents, a medical student, an NP who's reviewing with me, a physician assistant. You can imagine having 6 different people all coming to review patients with you at the same time. It's not a model for efficiency. It's not a model for great medical education. So we are doing our best in our own ED to try and limit the number of learners we have. But the number of learners that we can push through the system quickly is limited by the number of doctors that we have. I think recruitment is important. We do need a robust system, a medical education system that's responsive to the needs of the growing population. But we also need to focus on retention because I know that's where we're losing people. And there's only so many medical students that one doctor can train at a time. And I see Karen mentioning some of the issues with more for-profit or corporate healthcare kind of cherry picking, quote unquote. It's not a very nice term, but patients who tend to be healthier and have fewer complications, which makes sense. Yeah, sorry, Karen. Okay, I have a question from Brian Smith. Has Canadian Doctors for Medicare and others on this call endorsed and distributed the petition from the Ontario Health Coalition asking the federal parliament to enforce the Canada Health Act, especially the provisions around free universal accessible healthcare? You know, Brian, this is embarrassing for me. I cannot remember. It sounds like something we'd signed. Please feel free to put the link into the chat. We are in frequent conversation with the health coalitions and the Canadian Health Coalition surrounding these issues of shared concern. And then I see that Brian has made a comment in the Q&A. Public sector unions often take group plans for added healthcare, some of it delivered privately. How persuasively can you or me argue that public sector unions or any union should be supporting public and nonprofit healthcare, not profit-driven motives? Ooh, a little bit of a challenging question there. And any thoughts from Thara or from Chris? I know it's a bit of a deviation from our Alberta-focused conversation, but a good question.
Well, and I think public sector unions and all unions in Alberta are becoming very aware with Bill 11 what it would look like if they now have to negotiate for MRI benefits on top of their health and dental plans, or medical access fees, or testing, or so on, right? For surgeries, if that's all going to suddenly be added to employment plans, that really hurts their bargaining power in terms of everything else. And they were already aware of that with the fights for pharmacare and dental care, that if they could remove those things from the being attached to your employment to being a public service, then it changes their bargaining power. So I think they're already on board for the most part. Some of the public sector healthcare unions have been our biggest allies when it comes to things like pushing for universal pharmacare already.
All right, we're flying through because we have about 2 more minutes of live Q&A. Edward Shea has asked, the Premier has also indicated a desire to shift all public services to some element of private. What are you hearing about future changes? Oh goodness, don't tell me there's more.
The Premier has made it pretty clear that she doesn't want to provide public services, that they want to contract people to do it. And they're willing to fund some of them at times, but they don't see the role of the government as doing that. It's been already rolling out with the many changes that we didn't get to discuss, but you look to Recovery Alberta, one of the agencies they set up, and everything they've done since forming that agency for mental health and addictions has been private contracts to for-profit providers for treatment centers, for curriculum, for training, for corrections, and so on. And they're wanting to push that model into acute care and everywhere else as well, where the government might fund, but they don't actually provide the services. And they've talked about that very explicitly. The Premier talked about it this weekend, that maybe faith groups could take on serving, those who need it most, and everything else could be a private market. So it's a radical shift of thinking.
And a very scary one in this sector, because we already know, and this we're preaching to the choir here, but healthcare is not a good that can be delivered like any other business-based good. Like the best care for a patient is not always going to be the most cost-effective or profitable care. And it's just not reasonable. We have social services for a reason. It's one of the most core principles of this country to be able to provide adequate social services to ensure that every Albertan and Canadian can enjoy a minimum standard of living that keeps them safe and healthy. It's just terrifying to me to think of having leadership that believes in that so little. So it's definitely it's scary for me to imagine what else might be happening that hasn't been said yet, because I think each new piece that comes out just feels more and more shocking.
Thank you to you both. I'm going to have to be a little bit selective with the questions remaining. Jake's question, I feel like we answered a little bit with, how would we improve the healthcare system? There is a question from an anonymous attendee that I think is important because it comes up a lot. But an argument that proponents of this bill have is that Western European countries employ similar two-tiered systems and tend to satisfy medical demands by attracting competition. Is there an argument for this, or are we just comparing apples to oranges with Canada and these other high-income Western European countries?
Sure.
I think, oh, sorry, Chris, go ahead.
This is a tactic the government loves to use to avoid having a real debate. One, like pointing to Europe, that's not a country, that's many countries with many different systems. But they selectively choose countries to compare to depending what they're doing. They used to talk about Australia a lot, and now they don't want to talk about Australia anymore because things aren't going so well there. And they'll talk about countries in Europe, but they don't want to talk about universal drug coverage, which they have. They don't want to talk about physician ratios. They don't want to talk about the labor laws or tax rates or so on. They just want to claim, oh, there's two tiers there and it works great. We should do it too. They don't want to talk about elder care in places like Denmark, but they'll point to this. So it's not a genuine policy debate. It's a tactic to distract from what they're really doing. And what they're doing is creating an American style system. That's what they're bringing into Alberta. It's not anything else but that, but they're very upset if you call it that.
I completely agree with everything you said. And I think they are such different systems. Like, the challenges of our healthcare system are that we have a massive country that is almost the size of Europe. And we're trying to provide care. Even each province is in such a geographically massive space. We have challenges to providing care in rural areas, in very hard to reach remote areas where care will not be profitable in a private system. So it is very unique challenges to our system. And still many of the European nations that are often referenced still have even greater proportions of investment in social services and that social safety net than what we offer in Canada. And I think that's often overlooked.
Yeah, truly comparing apples to oranges, just to build on what Thara said. As I mentioned, 70% of health spending in Canada right now comes from public sources. Those numbers tend to be much higher in those compared to European nations. They're covering a lot more publicly. They have dental care, pharmacare, all these things that make sense and prevent extra expenses and complications down the line. So I often say that when people look at a country that might have slightly better outcome metrics than Canada and say, it's because they have two-tiered healthcare, that's like me looking at my brother and saying, oh, my brother's better than me at basketball because he's wearing, fancy Air Jordan shoes. My brother's 6'1" and I'm 5'6". There's other factors that could be contributing to that difference. Let's not pick this one random factor and assume that that is what is creating better outcomes. And I'd also even challenge that. I think that there's so many different ways to measure health outcomes. I think that a lot of the time we mythologize other countries as having like, oh, excellent, perfect healthcare systems, and no country outside of Canada is facing wait times or pressures. You guys, talk to somebody who's in the UK right now. I don't think that there's any health system around the world that's not facing pressure. Obviously, I do think we could do a lot better in Canada, especially for the resources that we have. But I do think that sometimes, the governments know that people mythologize healthcare in other countries and use that to their advantage. When Chris said what's being proposed would really much more open the way to more of an American style system. Okay, I've got 7:57 p.m. Eastern. I'm so sorry about the remaining questions. I'll see if we're able to keep a record of them and perhaps answer them narratively by email. I can't make any 100% promises. I'm not sure what disappears from Zoom when we close it out, but we'll see what we can do. As always, if you do have ongoing questions or things, you can contact us info@canadiandoctorsformedicare.ca. But I did want to thank everyone for giving us more questions than we have time for. I think that's always a wonderful problem to have. We always prepare for the possibility of crickets and we never have it. I really appreciate all of you sharing your stories and personal experiences in the chat. They resonate and it really just fuels our motivation for why we do what we do. Please join me in a virtual round of applause for our panelists, Thara and Chris. I think that you guys were both so powerful in your statements. Thara, your voice only got stronger as it went on. I learned a lot from the both of you. And if you are a medical student, resident, or practicing retired physician, and you're not yet a member of Canadian Doctors Medicare, please join today. It is free for medical students and residents. I'm always supposed to remind everyone that we are a very small organization. We have one full-time staff member. Don't tell our opponents, it's secret, because I think that people think we're a huge group. I think we punch above our weight through working with groups like Friends of Medicare. But we really could use your donations to keep going strong. So if this work has you fired up, I'd add to Chris's list of ways that you can help out is also to make donations to our organizations. And just wanted to close off saying that there's strength in numbers, and it's only by coming together that we'll bring about this real change. Sometimes it feels like we're shouting into a void, but all of our voices together, we have seen impact change. We won the Canby trial. We've made great strides in the past few years towards pharmacare, towards an interpretation letter and more public coverage of nurse practitioners and other providers. So we have seen substantial change result from campaigns like this. And I'm hoping that we'll use that to not despair as we end 2025. Thank you very much, everybody, and have a wonderful night.